because we've got the guys and the women's. So we've got to learn both. So if you have one of the sexes, you need to go spend some time on the other sex. There's one of the female cadavers, the one with the uterus. Who is that? What number? 4. Everybody needs to go take a look at 4 before you guys start the dissection today, because everything is like it's going to be clinically when you're in the OR or something. You need to look at how these structures are arranged before they start tearing it all out, okay? All right, so here we go. Orientation to the pelvis. You know, we know about the thoracic diaphragm. There's also a pelvic diaphragm. Right, so the thoracic diaphragm is this way. The pelvic diaphragm is that way. So concave, convex, encapsulating the intestinal viscera. If you look at what exactly is the pelvis? The pelvis is that area defined by the os coxae, C-O-X-A-E, the bony pelvis. If you draw a line from this thing right here, which is L5, S1, where they meet, that's called the sacral promontory. It projects forward. You'll see it in other slides. But if you draw a line from that promontory over to the top of the pubic symphysis here, that separates the pelvis into a false pelvis, which is on the top, and the true pelvis, which is at the bottom. And the pelvis has an inlet on the top and an outlet on the bottom. The things that are down here on your bottommost part is called the perineum. When we get down to the calf here, we're going to talk about a nerve called the peroneal nerve. Peri versus pero. So it's almost comical when somebody starts talking about the perineal nerve down here. But unless you're really saggy, there is no perineal nerve down here. That's peroneal. This is perineal up here. I'm going to have to be coughing all the way through this, so sorry about that. If you look at the bony pelvis, there are several features that you have to appreciate. The iliac crest is here. This is the ala, A-L-A, or the wing of the iliac crest. This is the anterior superior iliac spine, where you can feel right here. And down here where you can't feel, but it's above your acetabulum, is the anterior inferior iliac spine. This is the sacral promontory, and if you do if you find somebody, you know, like you guys went home and felt the spermatic cord in people, right? So if you go and find a female and you do a manual exam and you push back, it's pretty easy to feel the sacral promontory from the inside. Okay. Anteriorly, well, the os coxae is made up of 3 bones. We'll talk about later: the ischium, the ilium, and the pubic bone. Around the front here, the pubic bone contributes to the top and to the bottom ramus of this structure here. It forms a hole called the obturator foramen. And this comes into play when we start talking about pelvic organs. The obturator foramen. In trying to identify males and females, it's really quite simple. You just looked at the angle here. In males, it's more U-shaped, and in females, it's more V-shaped, as you see here. So when they're talking about identifying a skeleton out in the woods as male or female, this is the first place, one of the first places they look. The arcuate line, by the way, is this ridge that runs around inside the pelvic brim here. Right? If you look at the coxal bone itself, There are a couple of important points from looking at it. Now, this is looking at it from the inside. If you're looking at it from the outside, you're going to see the acetabulum. So we're looking at it from the inside, and this would be the articulation with the sacrum right here. All right, from the inside, you see these two notches. There's a greater and lesser sciatic notch. The notch. Greater and lesser sciatic notch. On either side of the lesser sciatic notch is either going to be the ischial spine or the ischial tuberosity. You are currently, right now, sitting on your ischial tuberosity. If you were to stand up and reach back here in your back and feel that bony prominence right here at the base of your butt, that's the ischial tuberosity. Okay? Any questions about that? All right. Go to the next one and look at the sacrum. The sacrum, of course, as I mentioned early on, is just a bunch of fused vertebrae. You have the canal that's in there, and we're looking at for the ventral side here. You have the canal that's behind the body, and then you have the ventral foramina, and you have the same thing on the back side would be the dorsal foramina, transmitting the ventral and dorsal primary rami respectively. Off of that, unattached to it is the coccygeal bone. Now, the coccygeal bone also can be fused or it can be separate bones. And there are like 3 or 4 of them. It's very variable. And the coxal bones are connected to the sacrum by ligaments. The coxal bones ordinarily are in line with the sacrum. They're kind of at the same angle, the curvature of the sacrum. In some people, they can be turned inward like that. The coxal bone can be turned inwards, projecting into the pelvis, and can cause a problem during delivery. You're usually going to know this when you do your pelvic exam prior to, well before parturition, which is the date of delivery, which is delivery. A friend of mine, where's Bonnarent's wife, when Sophie, she teaches Sophie softball, she fractured her coccyx because it was pointing inward, and when the kid came out, it just broke it. And it was really, that was really the most, if you ask her about it, that was kind of the most painful part of delivering, when she had her coxal bone broken. The ligaments of the pelvis, you have a very strong ligamentous attachment between the ala and the sacrum. This articulation you can see on an x-ray. It's very easy to see the SI joints on an x-ray. There are certain diseases that involve the SI joint. Actually, there's people who present with SI joint pain. You can inject the SI joint, and you can do maneuvers to try to realign the SI joint in chronic pain in that area. The obturator canal, or foramen, it's a foramen. Obturator foramen has a membrane over it. That obturator membrane, the top of that membrane is open. So it doesn't close the foramen completely. The very top of it is open, producing what's called the obturator canal. Now, if you look on the back of the pelvis, there are 2 ligaments that are very important. And we're going to find them tomorrow. There's a ligament that runs from the sacrum down to the ischial tuberosity, and another ligament that runs from the sacrum to the ischial spine, called the sacrotuberous and sacrospinous ligaments. What these ligaments do is they turn that, for example, they turn that greater sciatic notch into the greater sciatic foramen. And the 2 ligaments together turn the inferior sciatic notch into the inferior sciatic foramen. You can see right there's a space between these 2 ligaments. That's the inferior sciatic foramen now. That's the greater sciatic foramen up there. The notch is just a bony structure. In you and in the cadaver, it's the foramen that are important. Now, talk about the pelvic diaphragm. The pelvic diaphragm is made up of several different pieces and parts. This illustration right here, though, is very important, and this is a coronal section through the body. So here is our iliac crest. That opening right there, I mean, imagine this space right here and right there would be the obturator foramen. The obturator foramen is covered by the obturator membrane. It's covered on the inside by the obturator internus muscle and on the outside by the obturator externus muscle. Okay, everybody understand me here? They got a hole. The hole has a membrane with an opening at the top. On the inside, there's a muscle that arises from that membrane. It's called the obturator internus. Both of the internus and externus go to the femur. The obturator externus is on the outside of the pelvis. You would find it out here. Right? You find it out here. So this illustration here shows you the obturator internus. Now, the innermost fascia of that obturator internus has a gap in it. And that gap transmits an artery and a vein and a nerve. Right there. So this is the take-home message. You got the obturator membrane, internal obturator canal with a nerve, artery, and vein inside of it. This nerve, artery, and vein is very important, so you want to pay attention to this here as we go along. All right, so let's go to this picture here. What we've done is taken everything off the top, got all the guts out and all the reproductive organs. We're just looking down into the concave diaphragm at the bottom. Now, there are different parts. Here's the pubic symphysis right here. There's the sacrum back there. All right, now there are three muscles that come off. So if we put the pelvis back in order, it's a ring, right? It's a ring. So starting from the pubic ramus here, there's a series of fibers that come off of here. There's your pee hole right there. There's your rectum. It goes around the rectum. That muscle, you'll see it in another illustration, see it better in another illustration, is called the puborectalis muscle. The puborectalis muscle. Beside it, if we start going around the ring, coming off of the ileum here, actually it's coming off of the membrane of obturator internus. It arises from the membrane of obturator. Here's that canal up here. So here is this muscle here arising from the membrane of it, obturator internus. This is called the iliococcygeus. Now it says here pubococcygeus. This is the point I want to make. The puborectalis is the most medial fibers. Once you go lateral out here, still arising from the pubic bone, we call that the pubococcygeus. It's kind of the same thing, and if you actually call them the same thing, I don't care. Pubococcygeus, puborectalis. The iliococcygeus, though, like the pubococcygeus, wraps around the rectum. And if I told you to to elevate your anus, you can do that. Do it. You can do that. By levating your anus, that is the term, that's the name of the muscle, the levator ani. When you when you elevate your anus, It's the levator ani. Those two form 2/3 of the pelvic diaphragm. Now the other third is formed by this muscle way back here. It's called the coccygeus or the ischio-coccygeus. This muscle arises from the ischium, ischial tuberosity essentially, and attaches to the sacrum. But because it doesn't go around the rectum, it's not part of levator ani. It is part of the pelvic diaphragm.
Where does it go from the ischium? Where does it attach?
It goes from the ischium over to the sacrum. So that's called the ischio-coccygeus. You can also just call it coccygeus. That's another name for it, coccygeus. If you had a tail and you wanted to wag it, that is the muscle you would use to wag your tail. When you're on Jeopardy and you're talking to your mama this weekend about how much you learned in anatomy, you could say, Mother, if I had a tail, it is my coccygeus muscle that would wag it. That's what you can say, and you will be correct. But because it doesn't go around your anus, it's not part of levator ani, it is part of the pelvic diaphragm. If you look at it this way, here we are again. Here's the puborectalis, the most medial fibers. Beside it is the pubococcygeus. Beside that is the iliococcygeus. And back there is the coccygeus or ischio-coccygeus. That's the pelvic diaphragm. If I said, Scott, how are you doing?
Hey, good. Sorry to interrupt.
Oh, welcome to
We're
the
interrupting.
Yeah.
That is the best thing to interrupt right there.
Oh, yeah.
There you go. And I'm sure that he's saying, you know, when he was in school, well, this is the female one. There's McNeil right there. Welcome aboard.
Yeah, thank you.
Scott will be preaching to you hopefully later on, and
He works at the ER. He works for Mercy, so he's been out, I think he graduated what year was
2 years.
2 years ago, so you'll probably be rotating with him.
See you guys
He's
soon.
a good guy.
good to see you.
Yeah, absolutely.
Really?
Good luck with all that.
Thank you.
All right, so the problem with the pelvic diaphragm is, well, not the problem, actually it's a good thing that the pelvic diaphragm has holes in it, because you have stuff on the inside that needs to come on the outside. You can see the different male and female anatomies over here. The illustration down here shows you the different pieces and parts. Here's levator ani right here. There's a coccygeus. Now, there's one thing I want you to appreciate in this slide right here, is that is the diaphragm. That's the pelvic diaphragm right there. This stuff up here is not. This is actually called the urogenital diaphragm. You have another diaphragm we're going to talk about tomorrow, and that's it. So I want you to appreciate that today, though. Here's the pelvic diaphragm. That is the urogenital, the muscles and pieces and parts of the urogenital diaphragm. So if you were to look at it on a plane, the pelvic diaphragm goes like that. The urogenital diaphragm is right here. You appreciate that? Okay. The other thing I want you to appreciate is the relationship. If this thing right here is going to be filled with fat, so you can run, you can get infection. Infection starting out here can transmit anteriorly all the way around there. You can wind up with a huge infection down here because of the communication around and deep to the urogenital diaphragm. All right, here's the big point. Everything leaving the pelvis does so via the greater sciatic foramen. All of the vessels that are headed to your extremities and to your genitalia, all of the nerves, they all go out the external, they all go out the pelvis through the greater sciatic foramen. The problem is, though, you don't want everything to stay out there. You need to get some stuff back on the inside. And the way you do that is through the lesser sciatic foramen. Namely, the nerves, arteries, and veins that are going to your external genitalia. They're called the pudendals, internal pudendals and the pudendals. You'll see these here in just a minute. They, like the sciatic nerve going down to your lower extremity, and the gluteal arteries leave the greater sciatic foramen, but then they turn and go back through the lesser sciatic foramen, the pudendals. They go through that obturator canal on the inside of the obturator internus muscle, and then pop out through the arch of the pubis. Like that's the pubic bone right there. They come along, they go out the greater sciatic, go back in the lesser sciatic, wrap around on the inside of the pelvis, and come out on the top. That's how you get the innervation of the blood supply to your penis, your clitoris, particularly. Okay?
What do they come out of? Is there a name of the foramen that they come out of at the end?
Up front,
Yes.
we're going to cover that tomorrow.
Okay.
Yeah, but not really. They travel through the obturator canal right there. And then they travel over here and then they come out right there. When they come out, they're going to form the nerves, arteries, and veins of the penis or clitoris. And we'll name those tomorrow. Okay? Anal canal. Let's talk about the anal canal here a little bit. It's a fascinating piece of your anatomy. You have two types of muscles there. You have an internal anal sphincter that's under autonomic control, and you have an external anal sphincter that's under somatic control. If you have a big piece of feces headed down into your rectal vault, which is this whole area right here, the pressure has already caused your internal sphincter to relax. Your internal sphincter senses its presence and relaxes. The only thing keeping you from stooling yourself is your external sphincter, which you have under somatic control. Okay? This is not applied to sharks. That's another whole, you've had that problem. You know what a shark is? You know what a shark is?
Macy surely
Somebody-
does.
Somebody
She
reads.
doesn't know.
Huh?
Do you know what it is? Tell her what it is. What
Well,
is it?
it's when you
Children
think
know.
you're going to fart. But there's actual substance. It's a shark.
Oh my gosh.
If you look on the internal, it's a real thing.
They thought you said shark.
That's what I thought.
No,
Amy was confused, okay? She
not
needs
a
to
shark. If you look on the inside of the anal canal, there are two different, several different things you're going to run into. One is you're going to run into these columns, and then at the bottom of the column, you're going to have what's called an anal valve. Anatomically, they're not, you're not going to do a lot with them, other than the fact that when you're dealing with hemorrhoids, it's the vasculature inside those columns that becomes varicose to produce hemorrhoids, right? And remember the portocable issue with the superior rectal vein and the middle and inferior rectal vein. You'll see one of the subsequent slides has the arteries, but realize the vein goes with it. All right, there are two things right here that they want to emphasize. One is the pectinate line. The pectinate line is located right here, not at the level of the valves. It's important because above the pectinate line, it's autonomic. Below the pectinate line, it's somatic. in terms of the sensation. So when you have external hemorrhoids, because they're below the pectinate line, they're painful. You feel them as painful. If you have hemorrhoids above the pectinate line, they are not painful. So if a person comes in and they're talking about bright red blood, here's an acronym you'll run into. If you see that on the chart, that means bright red blood per rectum, or bleeding per rectum. If you have bright red blood, it's coming from low down in the GI tract. It's not a duodenal ulcer, it's way down here at the bottom. If you have drops of blood coming in the toilet, it's coming from right here somewhere. If it's not painful, then you have to, on your differential would be internal hemorrhoids. What would else be on your differential? If I came to your office and I said, well, every time I take a poop,
Colon cancer?
yes, well, not colon cancer, rectal cancer. If I say it's not painful and I see spots of blood, when did it start? Oh, about 8 months ago. Why haven't you been in before now? Well, it's never bothered me. It's just there. You know, I also have ulcerative colitis, by the way. I also have a family history of colon cancer. I also have, you know, this, that, and the other. I also smoke, and that should go to the top. The other thing is, a lot of people will do anoscopy. You know, if they have hemorrhoids, there's a little plastic thing like a speculum, like a vaginal speculum, but it's a round thing that goes in the anus to look for hemorrhoids and stuff. I never do anoscopy, because if I see a swelling right here, I cannot say unequivocally that's an internal hemorrhoid or that mass is due to a cancer. You're going to a gastroenterologist, let them biopsy. Okay? There was a case one time, early on I was involved with, the PA missed that, and the patient died. So, they did have internal hemorrhoids. She called it internal hemorrhoids. Just so happens she also had rectal cancer, and that was missed. So, yeah, that's the pectinate line. The white line is right here, somewhere down in here. It's not quite so obvious, or won't be in the cadavers, but the white line designates the difference between keratinized skin, like you have out here, and unkeratinized squamous epithelium. In other words, it's like a mucosa inside your mouth, right? The white line, neuroanatomically, is not really that important. It's just the distinction between keratinized or not. It's the autonomic line, or the pectinate line, that's the more clinically relevant. The rectal arteries, and again, note that they have associated veins within the superior hemorrhoidal or superior rectal, which is the last branch off of the inferior mesenteric. And then you have the middle and inferior vessels that are going to be coming off of the pudendal artery and the pudendal vein. By the way, it's the pudendal artery and vein, the internal pudendal nerve. Pudendal artery and vein, internal pudendal nerve. I don't know why there's an external pudendal, that's why. Okay. Any questions about that? Here's a nice illustration of the pelvic diaphragm. This would be the sphincter, so that part of the diaphragm going around the rectum would be the puborectal sling, S-L-I-N-G. Actually, when you look at this thing, you have the puborectalis going around it like that. Here's the sacral back here. Here's the pubic. The sigmoid colon comes in here like that. This muscle puts this bend in it and helps keep the stool above it while you're waiting to get out of class. Okay? when that sling relaxes, it makes the rectum more in line, and there you go. All right, the innervations of the rectum, here's our, this is the point I was making. Inferior rectal are branches off of the internal pudendal nerve. It says pudendal. Internal pudendal nerve. These are somatic. They come off of the ventral primary rami at S2, 3, 4. You know, you can contract your pelvic diaphragm. You know, not only can you contract the puborectal sling, you can contract your whole diaphragm. Those are Kegel exercises, you know, after delivery. Kegel exercises, they want you to do isometric contracting of your pelvic diaphragm to strengthen the floor of your pelvis. That's what that's all about. The hypogastric nerves that we talked about last week, coming off of, as an extension off of the aorta, they're the ones that give rise to the innervation of the mucosa and of the internal anal sphincter. Any questions about the rectum? We all have one in common. This is where we're going to diverge a little bit, starting with the female. Yes, ma'am.
So the sling you're talking about, is the sling just the same thing as the pelvic diaphragm or the lymph
No,
bladder?
the sling is actually part of the pelvic diaphragm. It's just the part of the puborectalis that goes around. Some people call it the puborectal sling. You might hear it either term, puborectalis, puborectal sling. It's easier if you think about it in terms of a sling, you know, to support the rectum like that. All right, female anatomy. There's certain things you need to know. Down here on this illustration here is our pubic bone, pubic symphysis. Right behind that is the bladder with the urethra. Behind that is the vaginal orifice, or introitus, I-N-T-R-O-I-T-U-S. Introitus is the opening of the vagina. It's angled upwards and backwards, and in the uterus, along with the cervix, sits on top of it. So if the vagina is faced, if this is the front, and the vagina is faced this way, the uterus is typically sitting on it like that. Now the angle of the uterus can vary quite a bit from person to person, but generally the angle is like that. Kind of like almost a 90-degree angle from the vagina to the uterus. Behind that, of course, is the rectum, and in the space between the uterus and the rectum is called the recto-uterine pouch of Douglas. Douglas, not the high school. The recto-uterine pouch of Douglas. Clinically, you'll hear somebody refer to there's no fluid in the Douglas pouch, or in Douglas pouch of Douglas or whatever. That's what they're referring to as the recto-uterine pouch. You'll see it later on. And in that cadaver, I want you to go and put your hand behind the uterus and put it into the pouch. It goes down in there quite deeply. It has a lot of clinical significance. The recto-uterine pouch of Douglas. Everybody understand where it is? Okay. Here's the uterus here. The vagina actually comes up and goes past the cervix a little ways. The cervix actually sits down in the vagina. Now the cervix is part of the uterus. So here's the vagina going back up here. You see the cervix sits down in there, and because of that, it forms a little cavity all the way around it. That cavity is called fornix. When you do a pelvic exam on somebody, they're lying down, and so the vagina is angled that way, and the cervix is going to be sitting right here. When you open it up, if they have gonorrhea, chlamydia, trichomonas, any type of abnormal vaginal discharge, where is it going to collect? It's going to collect in the posterior fornix. So you want to make sure that on your note you say the posterior fornix is without discharge. Or, you know, you found a grayish, thin discharge located in the posterior fornix. Everybody understand where it is? Behind the cervix, the top of the vagina. Of course, the uterus here has different parts we'll talk about in a minute. The fallopian tube or uterine tube, I don't care what you call it. And then halfway between the end of the fallopian tube and the uterus, you'll find the ovaries. Here's the pouch again. Oh, there's Douglas right there. There's the pouch again. And that cadaver, number 4, you can put your hands way down in there. It's truly impressive. Understand that if you're standing up and you have... if you're standing up and you have metastasis in your intestines, or if you have ascites fluid, or if you have pelvic inflammatory disease, or endometriosis, producing fluid, all sorts of things. If you're standing up, where is that fluid going to collect? It's going to collect in the pouch of Douglas. That's why it's so important. And you can see this on ultrasound. And they will tell you, when you send somebody for a vaginal ultrasound, in a vaginal ultrasound, they put the probe in the vagina. And that's the best way to see the Douglas pouch and the ovaries is a vaginal ultrasound versus a transabdominal ultrasound. But if you don't have anything, if the Douglas pouch is clean, that urine, that's good. You don't want anything other than a couple of milliliters of fluid in the pouch of Douglas. All right. If we look at it from the top here, here's the pubic bone. There's the bladder. What is that thing coming out of the bladder right there? Coming up the midline of the anterior abdominal wall. Huh? What is that? What's creating that fold right there? Not uterine anything.
Urachus?
Huh? So if you have the anterior abdominal wall, what fold is in the midline?
The
Going from the top
urachus.
of the bladder to the umbilicus.
Urachus?
The urachus. Did you say urachus?
No, I said
It's the urachus. That's the fold of the urachus. If we go laterally from there, what forms that fold?
Obliterated
The
umbilical.
obliterated umbilical artery. What forms the lateral fold out here?
Inferior epigastric.
Inferior epigastric. What's just lateral to the inferior epigastric? That's the deep ring, containing in females the round ligament. See? It's been a long weekend, hasn't it?
Yeah.
All right, so that's that. All right, behind that is going to be the uterus. Here's the round ligament. There's the oviduct. It's also could be called the oviduct. They say that term as well. And then the ovary is going to be buried in there. Now, notice right here, coming off of the lateral pelvic wall, these vessels. Those vessels are going to represent the ovarian artery and vein. Ovarian artery and vein. If we look at it here in this illustration, here's the ovarian artery and vein right there. There's that ligament, that fold that they're in, is called the suspensory ligament. It runs from the ovary to the lateral body wall. That's the suspensory ligament. So you got the brown ligament and the suspensory ligament right there. All right, the uterus itself. The uterus has a cervix. The cervix has an internal and an external opening called the os. External os. If you look at the cervix itself, microscopically, if that's the cervix with the opening in it right there, there's a transition of cell types in the cervix from squamous to sort of cuboid cells. This transition zone in some women is very apparent. You can look at a cervix and say, well, there's the transition zone right there. That's the transition from one cell type to another. The cuboid cells are internally, the squamous cells are externally, I believe. Cervical cancer, 99.9% arises from the transition zone. I don't know if that percentage is right, but I just made that up. But when you're doing a pap smear, if they tell you that the transition zone was not sampled, then you have a worthless result. You've got to go redo it. All right, so there's the cervix. Above the cervix is the body. The top of the uterus is called the fundus. In obstetrics, the fundal height is measured at every visit in centimeters from the top of the pubic bone. They measure the fundal height. It should be out of the pelvis at so many weeks. It should be at the umbilicus at so many weeks. It should be at the, halfway between the umbilicus and the xiphoid process at so many weeks. So you're measuring the height of the fundus as pregnancy proceeds. Interestingly, if you've not had children, you're a nulliparous. Some people call it nulliparous. And your cervical opening is just a round thing about maybe 3 millimeters across. If you've not had children, if you've not had a baby pass through the cervical canal, as it says that way. If you have, it becomes elongated like that, and it's called multiparous or multiparous.
What about kids through a cesarean?
It's nulliparous. It's got to go through there before it changes. Okay. Now, over here, there's an ovarian artery in the suspensory ligament. The uterine artery comes in from the side here, and there's a vaginal artery that comes in from each side of the structures. Those two are contained in a ligament we're going to tell you about in a minute called the broad ligament. But the uterine artery and the vaginal artery are in the broad ligament. I'll tell you right now, they come from a different place than the ovarian artery. Ovarian artery, what's the ovarian artery branch on? Comes off of the aorta. That's why it's running down the lateral body wall. The uterine and vaginal arteries, as well as the vesicular arteries going to the bladder, come off of what's called the internal iliac. And we'll discuss that here in just a minute. Internal iliac. Now, if you're going to take you've got the parietal peritoneum up here, right, under the diaphragm. You got it around here like that. The parietal peritoneum, if you just think about it, when it gets down to the bottom here, it just continues and covers all of the pelvis. That's called the broad ligament. The part of the parietal peritoneum that covers all of the pelvic organs is called the broad ligament. And it's called that in females. I don't even know if it has a name in males. But when you refer to the broad ligament, you're talking about the parietal peritoneum reflection onto the female organs, inferior. If we look at it in this illustration, so if I'm let me back up here. The way everybody always illustrates this is if my body is the uterus and my arms are the oviducts, and I'm palming two basketballs, those are the ovaries. If you were to take a sheet and just put over me, front to back, that's the broad ligament. Understand that the sheet wraps around the oviducts and it wraps around me front to back, right? And that's what this next picture illustrates. Now, by it being a sheet, remember you got a front side and a back side. It goes up and over and down the other side. Here's the broad ligament right here. The part of the broad ligament that's right beside the uterus here is called the mesometrium. The part of the broad ligament that's around the ovary is called the mesovarium. The part of the broad ligament around the fallopian tube, draped over the fallopian tube, is called the mesosalpinx. Salpinx means tube, remember from up here? Means tube. So the broad ligament has three parts: mesometrium, mesosalpinx, mesovarium. Here's the thing. If you put the sheet over me like this, so you've got one piece of the sheet going on this side of my arm, the other sheet coming down the other side, right? There's a space in between it. That space is where you'll find the uterine and vaginal arteries. It's between the sheets of the mesometrium. Now, if I put a tag in this thing, just call it the broad ligament. That's fine to me. If you wind up in surgery or OBGYN, they may be distinguishing, this is the mesometrium, or this is the mesosalpinx. You got to know the difference. When you do a BTL, bilateral tubal ligation, or if you remove pieces and parts of this, you'll be watching them cutting through the broad ligament. If you remove the uterus, it's called a hysterectomy. If you remove the ovaries, if you remove the ovaries and the uterus and the fallopian tubes, it's called an oosalpingo hysterectomy. OOSAL, oosalpingo hysterectomy, just like it sounds. What is that thing I say all the time? It's interesting.
Truly impressive.
It's really impressive to be able to say that word. We appreciate, you have to appreciate how impressive it is to say oosalpingo hysterectomy. Everybody all at once, ready? 1, 2, 3.
Oosalpingo hysterectomy.
So when a patient says, have you ever had surgery? And she says, yes, I had a hysterectomy. You have to determine, was it truly a hysterectomy? Or was it an oosalpingo hysterectomy? Because if you do an oosalpingo hysterectomy, you're going to send them into menopause. They will be postmenopausal that day. So if you came in and you said, I had a hysterectomy, you also then have the possibility of having ovarian cancer. Don't just assume that if somebody says I have a hysterectomy, they took it all out. Right? You get a 60-year-old who says they've got fullness down here, they're having bowel problems, they have bladder defecation problems. Yeah, I had a hysterectomy. Yeah, well, that ovarian cancer wasn't taken out 20 years ago. So you have to make sure. Did they take out all of the parts? Did you go into menopause? Did you start having hot flashes after they did this? You have to get more detail than I had a hysterectomy. Because to the layperson, it's all the same. Any questions about that? I would think that would be one of the things that you would pick up on. Or do you have any questions about that? Because I seem to say that all the time. That's not the big one.
We normally get like a 0.2
Okay, good.
turnaround for
Right.
this.
exactly.
No good. Yeah, no good. Okay.
Here are the two sheets of the broad ligament. There's the mesovarium, there's the mesosalpinx, there's the uterine artery and vein right there between the two sheets. And here's the uterine artery down here as well, a branch of it. So what I want you to appreciate right here is that the ureter goes underneath the uterine artery. By the way, when I say there's a branch of it, look right here. You see, this thing branches a whole bunch of times. It's not one artery that goes into the uterus and divides. You're going to get a whole bunch of branches out of it. Now, I heard you guys snickering like, oh, he thought that was the uterine artery, and then he read that was uterine artery down here. So he doesn't know what the hell that thing is. But it's something like that, you understand? Okay.
I was talking because you said you can truly appreciate.
Truly appreciate.
You're wrong.
Oh, yeah, okay. You can truly appreciate how I'm wrong. The point of this whole slide is that the location of the ureter is right up under the uterine artery. Becomes very important when you're removing the uterus, that the gynecologist, when they're putting vascular clips on there, that they don't clip the ureter. That's probably the most common complication of a hysterectomy is clipping the ureter. Then you gotta go back in a few days later when it's realized that they're not peeing and their creatinine is going up, that perhaps you've done something not good. So they have to get a urologist to go in there and fix it. Not a good thing. Happens way too commonly. The way that you tell the difference between the two, an astute surgeon, what did I say about the ureters? In pain with a stone. It's peristalsis. You sit there and look for a minute, there's peristalsis in that tube down there. There's no peristalsis in the vessel. All right, there's one other ligament here that's very important, and this is the one that really suspends the entire female anatomy from the cervix up. There's the cervix right there. There's a strong ligament that you're not going to find in the cadaver. It runs from the lateral cervix over to the ischial tuberosity. That thing is called the cardinal ligament, or the transverse cervical ligament. That's the main ligament that suspends the cervix and uterus. You know what I look forward to on Monday? I washed these scrubs over the weekend. They're clean.
Smell good.
You know, if nothing else good happens on Monday, you have clean scrubs on. You know,
The small things in life.
the what? So, anyway, Larry,
Yes, sir.
he and I coordinated again today.
Always.
This is what you don't want to see. You never want to x-ray a pregnant abdomen, and you can see the baby upside down inside that abdomen. One plain film x-ray of the abdomen increases the risk that that baby is going to develop a malignancy 40-fold. That's why you never, ever x-ray a pregnant uterus, no matter the size. Now, years ago, they used to, but obviously this film would be rather old. Nobody would shoot this x-ray today. Somebody kept asking me in lab the other day about pregnancy and where the uterus is and stuff. Well, this is, you put a baby in there, there's not much room for everything else. So this is a couple of points are illustrated by this. One is the reason why throughout pregnancy, pregnant women have to pee every 5 minutes. And you don't prevent a pregnant woman from going to pee, because they are going to pee. So usher them out the door as quickly as possible. The second thing is that where is the appendix on this woman? It is up here. So the appendicitis in third trimester appears as right upper quadrant pain, not like lower quadrant pain. There's another thing you ought to appreciate here. You're going to hear a lot in obstetrics about this. If we go back, let me just find it here. There's the round ligament right there. The round ligament attaches to the top of the uterus, comes out goes through the deep ring, down the inguinal canal, and inserts into the labia majora. Why you have a round ligament, I have no idea. The only time it ever comes into play is during pregnancy, because since it attaches to the top of the uterus, when you are looking like that, that round ligament is stretched all the way up here. And women will come presenting with lateral fundal pain I don't know how else to describe it. I've never experienced round ligament pain, but that's what is described, round ligament pain. Anybody in here had a child? Not the guys. You're not, I'm not after you. There's nobody in here, the mom? Wow, all right. Well, go talk to your mom. Ask your mom, did you have round ligament pain? And it's almost ubiquitous in pregnancy, round ligament pain. There's nothing really you can do about it. Tylenol and that's about it. During delivery, or during your monthly visits to the gynecologist or family doctor, whoever's going to deliver your baby, or most of the time the PA is the one doing these prenatal exams. You're going to have to determine is the pelvis itself big enough or wide enough to be able to allow for the passage of a child, namely the skull and the shoulders. Now the shoulders can squish in, but the skull, it can only squish so far. And if you've ever seen a newborn, they have this pointed head from being able to, from being compressed, getting through the birth canal. Usually it rounds out over a few days, but it can be startling the first time you look at your newborn child, and it looks like Jane Curtin and Dan Aykroyd. What are they called?
Coneheads.
Coneheads, yeah. Like, oh, they have no hair, and they're shaped like a cone, and like who you've been sleeping with. So anyway, there are certain angles that you can measure. And on a pelvic exam, you can actually, as I mentioned earlier, feel this sacral promontory and get an estimate on the distance. If the pelvis is not wide enough, deep enough, then that's a reason for cesarean. The other thing is that the width of it right here, called the interspinous area, or distance here, that's the narrowest part from side to side between the two spines. You have to make sure during a pelvic exam you feel those spines and you get an impression, yes, this is great enough to allow a child to go through there. Now, interesting, when you're during childbirth, the pubic symphysis here, in you sitting here right now, in the cadavers is very rigid. It doesn't move. But at the time of delivery, the different hormones cause that tissue to break down and it becomes lax. And the space between the two pubic bones at the time of delivery is about 3 or 4 inches. It's truly impressive how wide it gets. Taylor, why do you smile?
It's truly impressive.
It truly is. It's truly impressive. It's truly impressive. Because you look at this, like she couldn't have a goldfish. How is it that you get this head? Truly impressive. I thought of Kayla having a goldfish is what you were like. Oh, wow, that's kind of a neat thought. We have a snorter here. And she's getting ready to shark.
Okay.
Out of control.
Take a TV timeout.
Shark.
TV timeout.
All right, let's go to the guys. Oh, take a break. Have a